Most of the time, when there is a severe bone loss, we are not able to place an implant. So the plan going to be to first, we have to stage it, first bone augmentation, and then after the bone is generated, the bone is grown, we're going to go back and place an implant, which is going to be a two-stage procedure. And the length of those procedures are about something 8 to 10 months. But because of the anatomy, like a basically favorable anatomy that the patient has, even though with the severe horizontal bone loss, we are planning to place an implant and doing the bone regeneration at the same time. So it's going to show you the panel image of the area as a lower left bridge from number 18 to 21. It's an old bridge. Underneath the abutment teeth is a severe cavity there, and neither the patient and or the restorative dentist not willing to replace the old bridge with a new bridge. So our plan is to place two implants, area of number 19 and number 20. This is a challenging case, as I mentioned, due to horizontal bone loss that has. I'm going to go over the CT scan first so you can see our challenges and our advantages that we have. This is a tangential view. As you can see, it'll show you the nerve. The nerve is very low nerve, which is a very good advantage. So it's give us a good room to place a relatively long implant on that area. If I place planning my implants, like a two implants, number 20 and number 19, they're about 10 millimeter implants. But the disadvantage that we have, as you can see, if I show you the cross-sectional image on this case, look at implant number 20. I mean, more than half of the implant, it's outside the bony envelope due to horizontal bone loss. So in this situation, most of the time, the plan is to rebuild that bone and then come back and then place an implant. But since the nerve is low, as you can see, this is a mental frame, and our number 20 gonna go right over the frame, and which is we have enough distance. I mean, if we do the measurement here, you can see about more than 12 or 13 millimeter of the distance from the crest of the bone all the way down to the nerve. So the 10 millimeter is very safe placement, but the 4.1, which is a Stroman system, is a 4.1 millimeter. The width of the bone, more than half of it, is outside the bone. So how we build the bone? So as we know, there are so many different sources for the bone grafting. We have autogenous bone from the patient. We have allograft, we have xenograft, we have synthetic bone. But in this case, due to severity of the bone loss, our main source of the bone regeneration that we're gonna use is the autogenous bone. I'm gonna go to the axial images. I mean, this is gonna show you the severity of the bone loss. You can see how much the bone is narrowing down. Almost the whole buccal plate is gone. So first we have to know, okay, we know it's a severe bone loss and how much bone we need. It's very easy. We're just gonna go do the measurement through the CT scan. If I put my measurement here, as you can see, it's about 27.7, 28 millimeter of the bone is missing. So where should I get that bone? If I go further down, you can see on the retromolar area, I can harvest same bone right here. So what we can do is we can place those bone. I mean, actually, we're gonna go make it bigger through this. So you have a better idea about the bone harvesting area gonna be somewhere around this area. But before we proceed with the case, we have to plan it. We have to see, okay, I mean, how much bone we need, how much we can harvest, and also we have to take that one out, put it on the recipient side, and secure it. Most of the time for those cases, what we make a guide, a surgical guide for harvesting the bone. The plan is we only have to remove the cortical plate. We're not going to plan to remove any cancellous. It's very dangerous because if you go through the cancellous bone, you may get some of the nerve, we trap the nerve, or may pull out the nerve from the canal. That's why it's kind of like we always stay in the cortical bone for this area. As you can see with the macro saw on the straight hand piece, we make 2 incisions, one on the posterior area, one in the anterior area. The difference between the posterior and anterior cuts is, as you can see on the video, um, the anterior cut, you can sink all the way the whole depth of the macrosa through that, because as the course of the nerve coming through the canal and exit through the mental foramen, it will start through the buccal, then through the lingual. So as you can see on this area, we are almost at the mesial of the number 18, and then I'm sinking my macrosaw 100% deep through that area. It's very safe. You're not going to cut the nerve, because as we reviewed on the CT scan, the nerve is fairly inside toward the lingual part. So as you can see, all the cuts are ready to go. All they pass each other. You can see we pass through the cortical bone. We barely enter the cancellous bone, and I'm using the very small chisel. And with the chisel, I'm putting some wedging forces, like with the wedging it. And as you can see, I harvest the block. The block came out. It's a very kind of like a thick block. It's about 4 millimeter in thickness. And now it's time to split that block. So we never use a thick block for bone regeneration. As we know, is a Corey's technique. We split the thickness of the block. We need about 1 millimeter of the thickness as a buccal plate you need for bone reconstruction. And I use the macro saw and also for the beginning to draw my lines, and then the 22 millimeter flexible disc for splitting the bone. So I always hold it with my hands. I mean, it's nobody cutting the hand. You have to hold it very tight. It's be very careful. I mean, you can use hemostat ranger to hold it if you don't want to cut your finger, but most of the time it's my preference. I want to control it. I want to feel it, but I hold it like a hammer, very tight. I split those bone blocks in 2 pieces, and those 2 pieces are very big, because I only need 1 plate to reconstruct the buccal bone. That's the bone. It's all gone. The lingual plate is there. It's not missing, so I don't need to reconstruct the lingual plate. So what I do in this case, I use the other half of this split. I use my scraper, bone scraper. It's as you can see, it's from the Geislich, um, and I use it to get my autogenous chip. So by scraping that bone, I make it a little bit thin, going to be perfect size, about a 1 or 1.5 millimeter of the thickness, and we're gonna dip that Geislich scraper to the LPRF bone. We always draw bone for LPRF. That's going to help us for healing time and minimizing swelling or bruising that area. So I dip it there, and it's a good amount of the chip bone that we can harvest it from those blocks, and we use it for filling the gap, the void between the native bone and the block of the bone. That's the most important part of the procedure, because 90% of the osteogenic capability of the bone regeneration comes from that bone. If you remember, when you're using the allograft, they're saying don't pack it too much, don't push it too much. You need some spaces there. But when you're using the autogenous chip bone, definitely you have to go opposite direction. Just pack it hard, push it as much as you can. The next step is replacing those implants. So as we discussed, this is going to be a immediate implant placement in the severe horizontal bone loss. As you can see, I'm placing those implants, and you can see it like a lot of, it's a very thin bone, and few threads of the implant is exposed when we placing those implants. Now, so why I'm placing implant first and before securing my block of the bone, because implant placement is very specific place. We cannot move it. So it's this prosthetic-driven implant placement. So we have to place the implant on those exact placement. But if I put my micro screws before placing the implant, it may be interfere with the implant placement. So that's why we do place an implant, make sure this is good. We place an implant first, and then I place my macro screws. Those are Meiseninger screws. They are about 1 millimeter width, and then the length of those screws are different. So in this case, I use 3 screws, 6 millimeter, 8 millimeter, and 10 millimeter screws. It depends of the distance that we have between the block of the bone and the native bone. So we use a drill about 8.85 millimeter. It's a little bit less than the size of the screws. And again, we use tons of watering irrigation there to cool down the bone. And then we're gonna place those screws. As you can see, the screws is placed, and we have to make sure the plate is very, very secure, very kind of a sturdy. It's not gonna be move at all. And then at the last point, in the last stage of the procedure is to adding the bone chip. The bone chip that we got it from the scraper. We're gonna fill all those voids between the bone block and the implant and the jawbone. We're gonna fill it out with the bone chip. And as I mentioned it, you pack it very hard, just push it there, put it all the way in, make sure you have enough of those bone chips there, because those are the main osteogenic component of the bone regeneration. And when everything is finished, then we're going to close it out. As you know, whenever you use the autogenous bone, we do not to use any membrane. Why? The reason is because we have to have blood supply for our bone from everywhere. I mean, most of the blood supply comes from the host bone, but part of it, little bit, comes from the soft tissue too. So we don't want to make a occlusion or barrier to not to have our bone grafting receiving any blood supply there. That's why we don't use any membrane in these cases. And then the last part is closing. We have to close, bring the flap down, and suturing up. And then one of the most important part of this procedure is for my consideration is like we call it soft tissue management. First of all, you have it be volumizing the area. So there's a lot of more component to the jaw, and we have to bring everything back and close it out. So there is a lot of techniques for that, but the most important part is you cannot bring the edges of the flap or the gum and then push it and then suture it very tight. It will open up because of the function of the muscles in the mouth. Mouth is a very harsh environment. It's a lot of saliva, a lot of patient eat, drink, laugh, talk. So a lot of muscles movement. So all those muscles pulling the flaps, the gum away, and then you're gonna have exposure. So what's gonna happen with exposure? So anytime you have exposure, you losing your bone. It doesn't matter what you do. You might have the best bone graft in the world, but if the soft tissue closure is not strong enough, you have a premature exposure or opening in your flap, or any dehiscence in the flap, or any fenestration in the flap, you may lose part of your bone volume. So that's why it's very, very important that when designing your flap, you have to consider it at the end. You you're thinking, how should I close it? Make sure I'm not going to have any premature exposure on that area. So usually with the closure, I use the 5.0 PGA, and is about 3 layer of the suturing technique that I use for those. The first one is the technique that it's considering like a Stavola's technique, that he used the internal mattress suture that he used without any engaging the blood supply there. That's the first layer. Second layer is a horizontal mattress suture that bringing all the edges together. It's going to be a passive, no tension on it. And the last one is going to be either continuous, semi-lock, or interrupted lock suture to just close the edges there. And this is going to be our last stage of the procedure.